Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Get CME for this episode by clicking on a CME link in the show notes. Today, we welcome back L. Joseph Parker. He's a research physician. Today's Kevin MD article is titled, Vague Criteria Can Lead to Misdiagnosis and Prison. Joseph, welcome back to the show.
Thank you, sir. Appreciate it.
So Joseph has been on recently. Go to kevinmd.com/podcast. Upper right-hand corner, there's a search icon. You can search his previous episodes to hear his story. Today, let's jump right into this article. Vague criteria can lead to misdiagnosis and prison. What led you to write this article?
There is a specific problem with the 2013 version of the Diagnostic and Statistical Manual, which is DSM version 5, recently updated and added TR, but the problem is still there. Right now, I really want to talk about the confusion that can arise when you're trying to diagnose addiction in patients who suffer from chronic pain and the potential legal consequences of misdiagnosis and the differing opinions that people have about what addiction even is.
So tell us the challenges that you mentioned in terms of diagnosing addiction in those who are being treated with chronic pain.
Sure. Well, there's kind of a war being fought today between doctors who believe that it's all right to treat pain with medications that have been approved for that purpose, specifically opiate medications, and also doctors who treat addiction, and law enforcement personnel who seem to think that treating pain with opiates enables diversion and treating addiction enables addiction, especially when you treat it with medications, which many of them object to. And while they may not have the right to dictate the practice of medicine according to the Supreme Court, they absolutely have the power to do so, and they're doing it. And I wanted to go over some of the criteria for addiction in the DSM and explain why those criteria are so vague that they apply to every pain patient you have.
So let's go ahead and do that. How does the DSM-5 define
Okay.
addiction?
So, and first we'll say that the federal government and many states have laws forbidding a physician from prescribing an opiate for the purpose of treating what is sometimes called chemical dependency, other times called addiction. Now, the DSM-5 in the fifth revision, 2013, got rid of the diagnosis of addiction. You can no longer diagnose someone with addiction. Everything became substance use disorder, which is a spectrum. Before that, substance use disorder started here, and once it got really severe, then it became addiction. But now, addiction is gone from the diagnostic manual, and everything is substance use disorder, and that means if anyone shows the slightest symptoms consistent with a possible diagnosis of substance use disorder, both state and federal governments can now come in and say your patient had addiction or were at risk of addiction, which is one of the things they like to say, and you can continue treating them. Therefore, you had no legitimate reason to treat them. And that's sort of the code word that allows them to prosecute a doctor. They will say there was no legitimate reason if we don't agree with why you treated. You may think that you'll be able to make a coherent argument about it, but who are you going to make it to? These aren't doctors arguing with you. And they will find a physician somewhere in this country who will review your chart and assassinate your character and absolutely everything you did, and will basically say that I have seen in some extremes, I have seen it said that any other medication prescribed with an opiate is polypharmacy and puts them at risk, even an antibiotic. So doctors are prosecuted, and an expert will get there and say, well, he prescribed an opiate and an antibiotic, and that's polypharmacy, and that antibiotic could affect the opiate, and this could kill someone. And the jury, being medically naive, is there nodding their head. Now, if you were in front of a medical board, you would at least have other physicians. But don't think that's going to make you safe, because most physicians do not understand the diagnosis of addiction, mainly because it's not something we focus on in our medical education. It's a complicated subject, and neuroscientists are just now really discovering what it is. If you ask a neuroscientist, what is addiction? He will say, well, it's clearly overexpression of the gene delta phosphate in the nucleus accumbens of the brain, creating an uncontrollable urge to use a substance or activity for the purpose of creating the sensation of euphoria. Try giving that definition to a jury, and none of them are going to understand a word you said, and most doctors won't unless they'll kind of understand what you're saying. They'll kind of follow it. But how many doctors actually remember where the nucleus accumbens is, or what it's connected to, and how it's used? So this is the reward center of the brain. So the nucleus accumbens is where we feel euphoria, or where we feel good about doing something that has been evolutionarily good for us. We see something we find attractive, we have a stake, we win a competition. We get a little burst of endorphin in the nucleus accumbens, and that tells us we've done something good, do it again. Of course, opiates also bind these receptors and create that sensation. Addiction had been defined as the pursuit of that sensation of euphoria. Now it is defined by 11 criteria in DSM-5. And those criteria are impaired control, social impairment, risky use, pharmacological indicators like tolerance and withdrawal, time spent acquiring the drug or medication, giving up activities, physical and psychological problems, attempts to cut down, desire and effort to control use, time spent recovering from use, and reduce social, occupational, and recreational activities. The problem you're going to find as a doctor treating pain, let's say a man's has an industrial job. He's working at a tire factory, and his hand gets crushed and he loses 2 fingers. He comes to you right after his hand gets crushed. All right. So he's been to the ER. They had to amputate a couple fingers. Now he comes to you and he's saying, I'm in terrible pain. Now, a crush injury will often cause phantom limb problems. So he's feeling pain in those fingers that aren't there anymore. The severed nerves are just generating a constant pain signal. He's been treated acutely at the ER. Now he's coming to you for subacute treatment, and you start treating. Maybe you'll use gabapentin, or maybe even a benzodiazepine to try to suppress the pain. That doesn't work. You can use NSAIDs. You got to be a little careful with that. In some people, it does increase incidence of stroke and heart attack and all that, gastric ulcers. All these things have to be weighed. So eventually you end up with this patient on opiates so they can tolerate the pain and try to go back to work. Now, they will feel like their fingers are on fire, the fingers that aren't even there anymore. And you continue treating that person, and after 6 months, you still have that person on opiates because they cannot tolerate the pain without them. And they're saying it's hurting so bad, I need you to increase them. You're afraid of being criticized, so you're not increasing them. So he's still in pain, but it's better with the opiates. Now let's look at what's going to happen when someone comes to evaluate your practice. Impaired control. So if you ask him, can you go without your medicine? He'll say, absolutely not. Absolutely not. I couldn't tolerate it. And none of us could. If I put you in a bed as an experiment, I would never do this. Set your leg on fire and then beat the fire out with a baseball bat and put a bottle of oxycodone next to you and said, don't reach for that. I'm going out of the room. Most likely you're going to reach for that oxycodone. It hurts bad. None of us without severe chronic pain can understand the neuralgic pain that these patients get from nerve injuries. It is as painful for some of them as being on fire. And yet we ask them, don't want that medicine, right? Even asking for medicine can be seen as drug-seeking behavior, but it's not. It's relief-seeking behavior. And that used to be differentiated, but now it's not. Social impairment, what's that person going to do? They're no longer going to run around with their family and go do fun things. They're going to be cranky and grouchy, and their family is going to can be called in to testify, and they'll say, as soon as they started those medications, their whole personality changed. Well, the truth is, as soon as their hand was crushed and they started suffering severe chronic pain, their whole personality changed. But you can't prove that that's what it was. You can't prove that it wasn't the medicines. And remember, you're not arguing to doctors, you're arguing to lay people. Now, risky use. Do they ever take their medicine and drive? If they drive a car, of course they do. They're taking their medicine regularly. and they're driving. You've told them don't do it if it makes you drowsy, and quite often it doesn't make them drowsy at all. Because if your leg's on fire, it's hard to sleep. That's another problem. They take their medicine and they get drowsy and go to sleep, and their family says they're on too much medicine. When they take it, they go to sleep. But that's because they can't sleep in that much agony. You relieve some of that agony, and they're finally able to get a few hours of sleep, and that's taken as a sign of overuse and addiction, when all it is the brain trying to catch up on its sleep, because the pain has kept it awake. They will develop tolerance. The medications will not work as well over time. The enzymes upregulate, the receptors downregulate, and you'll need to increase the dose. You need to increase the frequency. And once they've developed tolerance and been on it long enough, they will develop physical dependence. Now, this is not the chemical dependence described in the law, but the juries won't know this. Physical dependence is just the body got used to a medicine. It happens to everything, including beta blockers. You take a beta blocker, it works great for your blood pressure for a few months, and then it doesn't work that well, and you've got to increase the dose. We all understand that. If you abruptly stop that beta blocker, you can put that person into a stroke or heart attack by spiking their blood pressure. Physicians understand that too. But by the government's definition, that person is now addicted to their beta blocker because they've developed tolerance and dependence. Now, the DSM-5 does say that tolerance and dependence should not be applied to persons on chronic opiate therapy. But what it should say is none of these criteria can be applied to someone on chronic opiate therapy, because all of them are suffered by these people, not because they're chasing euphoria, but because they're trying to get relief from their agony. Time spent acquiring the medication or drug. Their whole lives are focused around getting relief from their pain. So they spend an amazing amount of time trying to find a doctor who will prescribe it, trying to find a pharmacy who will issue it, trying to find a way to get to their appointments. They have to give up activities. That's criteria number 6. Of course they do. They can't work. And then unemployment. I have seen medical experts say, well, this person's now unemployed, therefore the opiate had impaired their occupational functioning, therefore they have addiction. No, he can't work because his hand is smashed and it hurts too bad. And he usually got fired while he was out and hurt. This is America, after all. We don't have a lot of support for injured workers. That's not from the opiates. That's from the pain they're suffering from. Chronic stress hormones go up, your neurogenesis drops, and you get depression. And quite often you develop anxiety and PTSD because something suddenly happened to you that caused you horrible pain and suffering, and you don't want it to happen again. Your brain's looking for it, and it cranks up your anxiety and your vigilance levels. Attempts to cut down. When you tell your patient, use the minimum necessary to make your pain tolerable, and they're able to go a day without medicine, they just discipline, they just fight it, and they're able to go a day, and then they test negative on a drug screen. That will be seen as an absolute sign of diversion, or that your patient doesn't need the medicine. Instead of applauding their ability to go on a drug holiday, which I had recommended to my patients, try to go a day, pick a weekend where you don't have to do anything. I know you're going to be miserable. Try to go a day without it. And if they could, that is proof that they are under control. But I have seen where experts will testify that the fact that you asked them to do that is proof that they had addiction and had lost control because they couldn't stay off of it forever. Well, they technically could, but who would want to? No one wants to be in agony. So attempts to cut down, you're always trying to cut them down. You're always trying to get them to cut down. And desire and effort to control use. If they say, hey, I would like to cut back, but I can't. Of course they do. Of course they do. We would all like for them to be able to cut back, but we also want them to have some quality of life. And, controlling the use, again, that goes back to human beings, just not being really good at tolerating agony. And I've said this before, suffering's always good for somebody else's soul. No one on fire ever said suffering is good for the soul. Time spent recovering, that really doesn't apply to someone on opiates, because but they will nap, they will take a nap once they get some pain release. And reduce social, occupational, and recreational activities, all of them. Whatever caused the chronic pain is going to reduce those. So all 11 of the criteria will apply to every chronic pain patient. And that leaves every doctor willing to treat patients with chronic pain vulnerable to prosecution. If you have not been prosecuted yet, it's not because you're a good doctor. It's because no one's been willing to lie about you or report if you're doing something wrong. If you're trading prescriptions for sex or cash, cash, not in patients paying cash for their visits. Some of them have to, and you can't take all insurances. Quite frankly, a lot of doctors don't like to take insurance at all. It's too much hassle. I'm talking about getting paid for prescriptions for patients you've never seen.
Yeah.
If you've never seen a patient and you issued a prescription for a Schedule II narcotic, you're in deep trouble, and you should be. But I'm talking about where physicians are being prosecuted under these criteria, because the government will take the DSM-5 into court and they will show the jury those criteria, and then they will get family members to testify. And again, the three things that I said, the disgruntled employee, an angry patient, and a jealous competitor. Those are the things that will get you in trouble. So when you fire a patient, they're the ones that are going to be in court saying he didn't do physical exams, he didn't do vital signs. And even if you have the records to prove you did, you have to go in front of a jury and prove you did. And these 11 criteria are going to be used to crucify you, because the pain patient has all of these. And they need to revise the DSM manual, and they need to add back the definition of addiction and the diagnosis of addiction, because no matter how pejorative it is, everybody knows what that means. And it's like when they tried to rephrase strokes as brain attacks. I remember when they did that. Let's not call it a stroke. We have heart attacks, let's call it a brain attack. Everyone pictured the old 1950s movies where the brain's jumping. No, it just wasn't good. Right? Stroke is good enough. Addiction is a good enough, descriptor for this condition. But it only fits when the person is engaging in these 11 criteria for the purpose of seeking euphoria, not for the purpose of getting relief from their pain.
So in this framework, what are some ways doctors can navigate treating chronic pain, short of not prescribing opioids at all?
If they have to document that these criteria exist as a result of their pain, they have to communicate with the patient and document the patient says that they cannot go without their medication, not for the purpose of feeling good, but for the purpose of not suffering horribly. It's very powerful to have things in the patient's own words. And I'm trying to work with some AI companies to get some AIs to quiz patients, to call the patient and quiz them, so that you have a daily marker of how they're doing. There's also apps being created so that the patient creates it. Nothing is better than a letter from the patient themselves saying, here's what my medications allow me to do. If I take my medications, I can go pick my kids up from school. If I don't take them, I'm stuck in bed. That is an improvement of function. If they say, without these medications, I might kill myself, that can be used against the doctor. But at the same time, many people don't want to live a life of agony, and they can't. And thousands of people are being thrown off their medicines unnecessarily right now. And many of them are choosing to take themselves out of the equation. And I can't say what I would do in that situation. But the fact that we might be lucky enough not to be suffering so horribly is no excuse to not empathize and put ourselves in that patient's shoes and try to imagine what we might do. Because when these patients get pushed off their medications, they are extremely prone to suicide and overdose, because they will try to buy those same pills on the street, and they are fentanyl-laced fake pills, almost always on the street. And that's what's killing people. Prescription medicines are not killing people. 90% of overdoses are not due to prescription medicines. Those studies were done assuming that all fentanyl was prescribed, because it could be prescribed, and like the Dawn study. And it also assumed that even heroin was prescribed. because you can prescribe something that has heroin in it. It's called tincture of opium. And it's for gastrointestinal problems. It's an old medicine, been around a long time. As far as I know, it's still out there. So tincture of opium can be prescribed. It does have heroin in it. You will test positive for heroin. So they said, since that can be prescribed, then all heroin overdoses are due to prescription medications. That's ludicrous. All they had to do was check the prescription monitoring program, and no one has done that yet. No one has looked at overdoses, checked the prescription monitoring program, and said, did this person have a prescription? 95% of people who develop addiction after being prescribed opiates had used opiates prior to being prescribed them and had just went to a doctor to try to get some. It's not like we prescribe opiates and a huge number of people suddenly become addicted. 4 to 6% of the population will have a genetic predisposition. We have to be aware of that. And it's a fact that we needed to be more cautious in our prescribing of these and our monitoring of the patients. At the same time, the government's heavy-handed response to this is absolutely exacerbating the crisis. You've got tens of thousands of people in agony on the street looking for something to relieve their pain, and they're dying.
We're talking to L. Joseph Parker. He's a research physician. Today's Kevin MD article is titled, Vague Criteria Can Lead to Misdiagnosis and Prison. Joseph, let's end off with some take-home messages that you want to leave with the Kevin MD audience.
For the patients, absolutely do not take yourself out of the equation. There are new medications that are being discovered all the time, some based on medications like ketamine that are completely different and can help increase synaptoplasticity and neuroplasticity and might be able to relieve this nerve pain problem. And this crisis will pass. At some point, things will get better again. And if you're not here to see it, it'll be too late. For the physicians, understand the threat you are under, that if you prescribe any controlled medication to anyone right now, you can be arrested and prosecuted for it. And you need to really study how to prescribe them and how to defend yourselves from these charges.
Joseph, thank you again for coming back on the show and sharing your time and insight.
Thank you very much, sir. You have a good day.